Is Courtney going to be up on the things? Hi, my name is Kathy Eckert. I'm a pediatric endocrinologist. Today I have with me two others on the team, Yolanda Ortega-Gamble. She's a registered dietitian and a certified diabetes educator. And Stephen Graybar, who you may know, he's a clinical psychologist who has worked in our pediatric diabetes clinic for quite some time in the past. So we are starting again today the 4-month cycle or series of pediatric diabetes. And subsequent to that, we're going to have a pediatric endocrinology series as well for several months thereafter. And then we're going to start in general pediatrics, having many different subspecialist guests speak on different months about different topics. So this is kind of the kickoff. And with that said, I want to open it to the members who are signing in today and just kind of get a feel for what you would like to hear from us. And also if you've brought some cases that we can talk about today as well. So today's topic is really meant to be more about type 1 diabetes, but we're open to talking about anything in terms of diabetes. The series will include type 1, type 2, and other types such as MODY diabetes. And then subsequently, we're going to have the psychological aspects of chronic disease management, particularly diabetes, and also looking at insulin pumps and continuous glucose monitors. So that's just kind of a little heads up for what we're going to be doing, but we're not set on any particular schedule necessarily for today. I do have some slides, and I want to look at some of those, but I also want to just keep an open dialogue and talk about what you have questions about. And you can always ask questions of anybody on our panel this morning as well. Okay. Did anybody bring any cases or questions with them this morning? No? Okay. All right, and that's fine. So in the future, I think that we'll bring some actual cases with logbooks and continuous glucose downloads and insulin pump downloads and so on, so you can actually see what those look like, and we can guide you through how to make correct adjustments on insulin or maybe food as well in order to improve compliance as well as control. Okay. Can we start my slides, please? Again, I'm not going to go through every single slide, and you'll have access to these, so I don't want to have this be tedious by any stretch, okay? Please feel free at any point to interrupt and interject and ask any questions or comments that you might have, okay? Okay, so it's been interesting over the last 10 years. The incidence of type 1 diabetes has increased quite significantly, and there's some interesting theories behind why that is. Currently, the thought is that the prevalence is about 0.5%. You see here it's 0.2 to 0.5 on my slide. It's really going to the upper end of that now, so 0.5%. When I was in fellowship, they said it was about 0.1 to 0.3. So we're also seeing a difference in terms of the age at onset and at both extremes. And on my slide here, you know, the classic is up to 40 years of age, and after that, it has to be something besides type 1. That's really no longer felt to be the case. And there's people who have been diagnosed as old as 70s, 80s, based on autoantibodies, okay? And there's some problems with those autoantibodies that we will speak about. But generally speaking, there is no age at which you cannot be diagnosed with type 1. And I think that's really important to understand, because a lot of times we just have a preconceived notion of, oh, you're 30 and you're overweight and therefore you must have type 2 diabetes, okay? And that's not always the case. The other end of that spectrum is that we're seeing a lot more cases being diagnosed in the under 3-year set, including 8 months, 12 months old. And that does raise some other questions about what type of diabetes this is, but we are seeing actual autoimmune type 1 diabetes in that age set as well. So it is an interplay, genetics, autoimmunity, and environmental. And of course, what those triggers are for any individual can be completely different depending on the person. The symptoms, I think everybody realizes. The important thing I want to really point out in the pediatric population, and especially the younger kids, the weight loss and the symptoms can come on very, very suddenly, and those kids can get into trouble very, very quickly. adults can maintain. They have more body fat. They have more means of keeping hydrated and keeping their food going, perhaps medications to keep the food down so they're not nauseated all the time. Babies can go south pretty quickly. And so if you see a baby who's very dehydrated and out of the context of whatever illness is happening, please always think about diabetes, again, especially in that context of the increasing frequency. So generally, we do hospitalize for type 1 diabetes in pediatrics. and adults, I don't think that's the case. But the reason for that is primarily education. And it really takes a team approach to educate the parents as well as the child, and also stabilize them from a blood sugar and acidosis standpoint. Now, fraught with difficulties because not everybody has a team and not everybody has a hospital that is equipped to teach these patients. And so generally speaking, they are sent to a referral center for that. So we're going to look at a little more carefully a big graph or a big table that I have on all the different insulins. But bottom line is you need to try to act like a pancreas, okay? Which is easier said than done, of course, because we don't have all the sensing mechanisms. But as far as the insulin goes, we try to have one long-acting and then short-acting insulin that's going to take care of the food. So a basal insulin generally is Lantus, Levemir, or Basaglar, or now Toujeo. And our short-actings are Humalog or Novolog, or Apidra. And we tend to use the Apidra in the little guys because you can do that postprandially after you know what they actually are going to eat. And it doesn't take as long to kick in. And then we are going to have a whole segment on insulin pumps, so I'm not going to go over that right now. Okay. So as far as food management, again, we're going to go into more depth with this with Yolanda in a couple of months. But basically we use carbohydrate counting. So there's not a sliding scale per se that we use, other than to say we use a correction bolus. So, but that doesn't take into account the food. So we really have to teach these patients how to carbohydrate count. And the reality is that most people eat about 25 of the same things every single week. So you have to learn 25 things and then you look up everything else as it comes up. Now that sounds pretty easy for everybody in the room. Obviously it's not in real life, and especially for children. And that is one of the big issues that we have in terms of adherence and gaining better control of blood sugars. They don't care and they don't want to look everything up. So they don't accurately count their carbs, and therefore they don't accurately give insulin, and leads to all kinds of issues. Usually high blood sugars, but sometimes they overdo it and just say, I'm going to take 15 units, call it good, and then we see lows down the road. Okay. So one of the downfalls of our current day management, without a pump anyway, is that it takes a lot of work. And with that becomes a lot of adherence issues. So our usual regimen is as you see here. It's a lot of finger pokes, it's a lot of shots, it's math, it's finding your insulin, it's having it on board with you when you're at school, for example, or out to dinner, or whatever the case may be in children. And so with that, my guesstimate is that probably patients get 75% of the prescribed insulin that they're supposed to be getting. What do you guys think? Is that?
Yeah, I'm thinking too that a lot of the time when you talk about challenges, not just that they don't want to look it up, but we have a fair amount of patients who just simply can't do the math.
Yeah. Mm-hmm. In which case, sometimes we'll use just regular consistent doses, assuming that they're eating X amount of carbs at every meal. And so we'll just prescribe sometimes even a 70-30 mixture of insulin if that's all that we can get them to do. But ideally, we're giving a long-acting plus a short-acting, except in certain instances. So here is the table for A1C. I'm sure everybody's probably seen this. It's interesting that the talk now with so many people being on continuous glucose monitors is that the A1C is maybe becoming a little antiquated. And some big centers are actually leaning away from it because you can get artificially, you can be satisfied, I suppose, with an A1C when in fact what's really happening is they're all over the map. So if you average a bunch of 50s and a bunch of 300s, you're going to have a great A1C, right? It's going to be 7%, let's say. But that's not really telling you that the patient is doing well. So many bigger centers now are relying more on continuous glucose monitor data and really looking at that very carefully as opposed to getting an A1C. Or fructosamine, which is a shorter window, or smaller window and view of what your blood sugars are really doing. It's more 4 to 6 weeks as opposed to a 3-month view of what your blood sugars are doing. Okay. So for the time being, we still do an A1C every 3 months. But we also look at that in the context of, hey, what's in your download? You know, when they come in with their meters, we try to download those, and most of the time we can. Sometimes we have technical glitches, but we look at those, and if those are really far off, then we say something's wrong here. Either you're having a lot of lows in the middle of the night that nobody is detecting, or you're having a lot of highs, depending on what the A1C shows, that you're not seeing because they're all postprandial, and you're only checking your blood sugar right before a meal. So how many of you that are with us today, how many have kids under the age of 18 with type 1 in their practice? Anybody seen any, or type 2 for that matter? No. Okay, so you will see them, and you know, whether that's the initial presentation or whether they're coming in already established or already diagnosed, and know you will be seeing them, if for no other reason than the incidence is increasing. And quite rapidly. So I don't really want to go through too much of DKA here. What I really would like to focus on is some of the problems that we see most commonly. And you know, what are the pitfalls and what can wreak havoc with the patients in terms of their diabetes management? And then what are the long-term effects of that too? Which are really important that we need to screen for, but also talk about with our patients. So I would say that besides adherence, probably the biggest thing that we see is hypoglycemia unawareness and also lipohypertrophy. And I think those two are actually related. So who here has actually seen a patient who has significant lipohypertrophy from insulin shots? Anybody? So I wish I had a picture, I don't. But so when we examine someone, you look at where their normal sites are of their injections. And a lot of times, especially on the belly, you can see these humps. They actually look like buffalo humps. And, oh, beautiful. Here we go. He's gonna pull up some pictures. Beautiful. It's impressive. You know, can they see these? Yeah. Okay. So yeah, just take a look there, and I mean, amazingly enough, people will continue to put their shots into these lumps here, and the reason for that is after a while you don't feel it. You know, you completely lose sensation. You've kind of killed off all the nerves there, and so they just keep injecting. Well, the problem with that is the insulin gets locked in to that lipohypertrophy. So instead of working, your Novolog working within an hour or so, you might see it come out and into the bloodstream 3 to 4 hours later. So your food's already gone. And that's when we see these massive lows in people that is kind of out of keeping with, well, what they said. Well, I took my insulin right before I ate, and then 4 hours later, I have a 30 on my blood sugar. And that's the first thing to think of, is probably lipohypertrophy. The only way to get rid of this is to stop using those sites altogether. Okay. Now, when people say, well, but I love that place and it doesn't hurt and it works well and so on, it's a good argument because they're right, it doesn't hurt, but it doesn't work well either. And so if you really think about it, there's a huge amount of surface area on the body where you can do it, even little kids. So we use the belly, the legs, the buttocks, and sometimes the arms. In little babies, it doesn't really work so well for the arms. There's just not that much meat there. But everywhere else you can. And on your belly and legs, there's a huge amount of surface area that you can use, okay? So that would be number one. You can also see lipoatrophy, which is almost in the center there, the person with the yellow shirt that's tucked up. We don't see that too much anymore, and that was really due to having pork and beef insulin and the antibody reactions that we saw to those animal types of insulins. So with human insulin, we don't really, or recombinant DNA insulin, we really don't see that anymore. Okay. Yolanda, if I could, do you want to talk about some of the common dietary things that we see?
Yeah, I was going to say too, just in terms of avoiding the lipohypertrophy. So I'll sometimes do things like print up, we have pictures that show different places that you can cite, that you can inject. And so I'll have the parents like buy stickers, or I'll give them stickers, or color in an area. So it gives someone who's maybe like 4 or 5 or 6 years old the ability to say, like, I want to use that spot, or we already used that spot. So it gives them something different to focus, and then it also focus on, and then it also gives sort of a bigger picture visually of where they've used, because I think it's just hard to keep track. They're out and about, and they just tend to go to those same areas. And so those are some techniques too. In terms of dietary stuff, we want to avoid teaching kids that foods are good or they're bad necessarily, and we want to avoid having too much emotional weight tied to the foods, which can be really hard with type 1 because they feel that they've been good or they've been bad. Is the number a good number or a bad number? So we try to teach the kids too to just that we're being detectives. It's not that a food was good or bad. There's lots of reasons the blood sugar could be high besides the last thing that they ate. So I try to teach parents to be really cautious about not saying, oh my gosh, we're never going to eat pizza again. Look what it did to your blood sugars, because it's not taking into account sort of the activity earlier in the day as well. So I think probably the most important thing to do is try to sort of normalize everything. We also try to keep kids, kind of put them back to eating more or less the way that they were eating before, so they don't feel like, oh my gosh, I have diabetes, now we have to change all of these crazy things. So we try to return them to that. And then I was a dietitian long before I was a diabetes educator, so I do obviously don't want kids eating Fruit Loops 3 times a day, but I work on that a little bit more slowly. At first, we want to make sure that they sort of feel like this is normal and you can do it and it's going to be fine and we don't have to change every last thing under the sun. So I'm just always really cautious about never presenting that, feeling that this was a bad thing to eat because this is what our blood sugar was. It's more like we're being detectives. We're all collecting information so that we can look for patterns in your blood sugar.
Anybody have questions about kind of general carbohydrate counting or just general background information about diabetes and nutrition for children? Okay. So Steve, would you like to talk a little about either adherence or, one of the things that I see is just parents either inability or unwillingness or maybe both to make changes in between appointments and motivation, I guess. You want to speak to that a little bit?
Well, it's psychologically, it's a fascinating process. It's devastating as well. My youngest consult in PICU was for 5 months, if you remember the couple that was traveling. And so if you can imagine bringing a 5-month-old baby into the pediatric intensive care unit and then telling them what they're about to face. I mean, with all their hopes, all their dreams, all their fantasies of what childhood is going to be about, this does not fit. And we had a number of parents who just could not bring themselves to finger poke their infants. Turning their fingers and toes to hamburger is really because this particular family that I was thinking of, I think they were testing up to
10
times a day. And so on one end of the continuum, you have parents who are obsessive, who we prefer, but not obsessive and compulsive, in which they're over the top and completely suffocating their child. And on the other end are parents who, people like to use the word denial. I'm not a big fan of that in this context. They're stepping away, they're avoiding and stepping back, and they're much too passive. And one of the big problems I think that I've seen in our clinic was that parents were prematurely turning over diabetes care to their children. I've been outing my sons for many years, but I used to just say that I watch my kids brush their teeth into their teens, for God's sake. You're not going to have your 9-year-old test their blood, count their carbs, and inject on their own. It's just turning it over far too soon. And that is an understandable defense against the pain of having an imperfect child. I mean, that's our fantasy for all of us, right? 10 fingers, 10 toes, a beautiful smile, and an IQ of 190. It's not happening in dramatic form. And so families get blown apart by diabetes because of the stress. And I think the team that I was on with Dr. Eckert and Yolanda and Dr. O'Connor, I think we did our best to pull families together around their diabetes. And families who were able to do that really thrived in amazing ways and actually found meaning in this dreaded disease. And their adherence was better, much more solid, and yet they weren't so rigid as to live number by number, test by test. And so we can role model for them certain ways of coping and approaching. And I think both Dr. Eckert and Yolanda do great jobs in just not panicking or overreacting, but certainly not underreacting. And you can imagine with the span of people that you see in terms of their level of education, their level of income, their capacity to really appreciate long-term consequences. It's a real challenging disease and illness to manage for them and for you. And you have to make connections. In my opinion, if we don't connect with the parents, if we don't treat the parents as if they are at least in part a patient, they are your number one. And we don't treat diabetes, they do. You consult, you educate, but in terms of treating it and managing it, they do until it's too late, and then they're in DKA, and they basically get to call time out on their role psychologically and turn things over to the physicians and to the hospital. So does that sort of?
Yeah, and I think one of the biggest issues too is nobody gets a break from this ever, and that psychologically and otherwise is pretty significant. And people need a break, and oftentimes nowadays we don't have our whole family together. We don't have grandparents to help take over. Sometimes we do, or babysitters don't feel comfortable, or the school doesn't necessarily feel comfortable. And so this whole load is on the parents, and oftentimes that may be one parent. And so that parent has pretty high burnout rate as well. Some options that we have, they're kind of few and far between, honestly, but diabetes camp for a little bit older kids. When you hit 6 or 7, you can go to diabetes camp, so the parents and the rest of the family get a little bit of a break. Their whole life isn't designed around taking care of and managing the one child with diabetes. And so that's important for that to happen. There's also family camps where everybody goes, but everybody's the same. And so I think that is very meaningful to the parents as well as the kids who are there, because they're not different anymore. And everywhere else they go, they are the kid with diabetes, no matter how you look at it. Even if there's 3 or 4 kids in an elementary school, they are the kid with diabetes. And so that's a big challenge as well.
It's interesting too when you go to diabetes camp as a person who doesn't have diabetes, you definitely feel it. Everybody there, I'm kind of like watching from the outside, and everybody everyone who has diabetes has this very special connection, and you're sort of not aware of it until you are the odd person out. And it's really heartwarming, and it's a little uncomfortable. I'll say it's a little bit uncomfortable just to kind of watch that, because you definitely feel on the outside.
Yeah.
I thought it was kind of cool because you just don't know.
You don't. Yeah, it is a very strange feeling.
Mm-hmm.
And we are the outsiders. When they're in our clinic, even though there's a lot of other kids with diabetes there, it's definitely not the same. You know, we get 100 kids with diabetes in one setting, or the teen camp is maybe 30 or 40 kids, and it's definitely a different sense.
I just bring a meter to fit in.
Yeah. It's hard too, because you kind of walk that fine line. I think there's a lot of dietitians and diabetes educators who do have type 1 diabetes, and I'm not one of them. And so I always try to be really respectful and really mindful of the fact that I truly do not know what it's like to have a child with diabetes or what it feels like. So I'm always very, try to be as respectful as possible and not, overstep that boundary and act like I know how easy this should be for you. No way. Because that's just going to alienate a family.
So if there's questions, please feel free to ask them. Otherwise, I was going to talk a little bit about some of the long-term, short and long-term complications that we see. And as Steve mentioned, diabetic ketoacidosis. And we have a subset of our patient population who frequently go to the emergency room and then into the ICU. And clearly there's adherence issues, perhaps education, socioeconomic issues. I mean, it's so difficult to tease all of that out. But we have probably 15 to 20 kids who on a very regular basis are being readmitted to the pediatric ICU. With that, every time that happens, you have a bigger risk of having something permanent happen. And we've had a couple kids just in the last year who have had significant central nervous system problems because of that. They are so acidotic. Or conversely, sometimes we see these very, very severe hypoglycemic episodes. And a lot of times that's in the middle of the night. So they may take some insulin at bedtime, or they have the lipohypertrophy, and so there's no food left. And all of a sudden, all that big bolus of insulin finally kicks in. They're sound asleep. They don't recognize it. And that is one of the most concerning things that I have. DKA, that's pretty obvious when it happens. Someone starts vomiting, they're breathing differently. Someone's going to probably notice that. But hypoglycemia, you can just kind of drift down, and pass away in the middle of the night. And fortunately, that doesn't happen very often. But one of the things that we see is the longer you have diabetes and the more often you have hypoglycemia, the less likely you are to mount the normal response. So our response without diabetes would be glucagon, your own glucagon kicks in, epinephrine, cortisol, growth hormone, all of those things kick in as counter-regulatory hormones and then increase your blood sugar very, very nicely. And in fact, in most of us, we wouldn't even get down to probably less than 60 or so because we have all those counter-regulatory hormones. But our bodies adapt, just like to so many other things. And so when you're constantly having lows, it goes, wow, I'm just kind of tired of doing this. And so it doesn't kick out those counter-regulatory hormones. So we've had, and in fact, your brain becomes so accustomed to this, and it probably happens relatively slowly, so it doesn't even mount seizure activity, okay? Because your brain just kind of gets used to that, and it doesn't trigger seizures. So obviously devastating and just horrible when this happens. And again, we've had several kids who have had profound CNS depression because of it, sometimes permanent. Fortunately, kids' brains are pretty plastic relative to adults. So many times they do bounce back, but they're never quite the same. Okay? So that's probably my biggest fear. And lipohypertrophy and lack of observation or interaction by parents, I think, are the two biggest reasons for that. Sometimes we have intentional overdose, and that's a whole other topic that maybe someday we can talk about. A lot of psychological issues behind that, particularly attention seeking. But most of the time it's kind of accidental, overdosing oil of lipohypertrophy. Okay. DKA though is by far more common, and that one's pretty easy to figure out. It's generally a lack of insulin and lack of checking your blood sugars, so you don't really know what's going on. And if your A1C is 10%, let's say, you're this far away from DKA all the time. If you're in good control and your A1C is 7, it's going to take a whole lot more, because all of your counter-regulatory hormones and your blood sugar control itself is so much better. It's just going to take days as opposed to hours of not having insulin by the time that you actually are in DKA. Okay. And on that note, a lot of people, and we'll talk more about pumps one day, but a lot of people really believe that being on an insulin pump is the end-all be-all, and this is going to be a piece of cake, and I don't have to worry about it anymore, and Johnny is just going to do great all by himself. And so a lot of times we see an increase in the A1C and worsening of compliance and so on once they're on the pump. So we try to choose our families very, very carefully with who gets pumped. And it was interesting, I overheard a conversation by Dr. O'Connor, who's in our clinic yesterday with a family. And the parents are divorced, and the dad said, well, I want to buy Johnny a pump, and so let's get him started on the pump. And mom really wasn't all for it. But dad wanted to proceed. And so Dr. O'Connor had to have this conversation with her and said, well, if everybody's not on board, we're not going to do this, because the child is 50% with each parent. That doesn't work very well if one person's not on board. And especially if dad's doing it, or whatever parent is doing it, because they think it's going to be easier. It's a huge step up. And that much more likely you can go into DKA. If your cord kinks and you're without insulin for an hour or two, you're in DKA. If you forget to put more insulin in the syringe, hour or two, you're in DKA. So there's a lot of things that can go wrong with that. And Yolanda does a lot of the pump starts. So why don't you speak to kind of the things you see with education and follow-up?
I feel really strongly that we want to sort of pick the right families and the right moment to start a pump, because we want it to be the most positive experience possible. And so there's definitely people who do better on pumps and people who don't. We have siblings where I can think of one family right now, the older son is in high school and wants nothing to do with a pump, never has. Little brother is maybe 7th grade, was diagnosed and wanted to be on a pump really quickly, like maybe within 6 or 7 months. Older brother still, I was interested to see if the older brother was then going to want to switch to a pump, and he doesn't. He has no interest in it whatsoever. But I think we try to refrain from putting people on pumps until they're out of their honeymoon phase, because this has happened a lot too, is if their honeymoon phase will coincide with putting them on the pump, then it just sets up for a negative experience, and they feel like their blood sugar's going up and all needing more insulin is actually related to the pump, like they associate the two together rather than
How long would you say?
Weight?
No, the honeymoon phase or weight.
Right. So the honeymoon phase can be non-existent depending on when diagnosis was and whether there was DKA or not. But then some will go on as long as a year and a half, probably 2 years, depending on how quick you figure out someone has elevated blood sugars. A lot of times there's somebody in the family, either a parent or a sibling, who already has diabetes, and so the family's like on it, and they can tell the child's blood sugars are starting to rise, so they don't go into DKA, but they catch it really early on and might not need insulin in some cases for a little while, or they need very small amounts of a long-acting insulin, or maybe just fast-acting with one meal. So they can ride that out for a pretty long time. The earlier we catch it, the longer the honeymoon phase is, right? So we try not to put anyone on a pump before the honeymoon is over. It's also difficult to sort of nail down what doses are when they're still in the honeymoon phase. You can get away with a lot before that sort of abrupt ending, when there's no more insulin left in their body that they're making. So try to look for things. I feel really strongly too that the people that do best on pumps are the ones who have a really good handle on their diabetes with MDI, multiple daily injections. The better grasp they have of that, the better they tend to do on a pump. The people who come in and feel like, oh, I'm not going to have to carry as much stuff, that's always their big thing. Like, oh, I won't have to carry my pens anymore if I'm on a pump. And so we try to walk through everything that they'll have to carry, and they have to carry more because you actually need to carry your pens in case there's a pump failure. And then you also need to carry all of the things to do a pump side change if there's a failure as well. So try to walk through and sort of, without being too negative, depending on how much you want to sway the family, how many things you might point out that are on the pros or cons list, you can kind of adjust that to put them off for a little while. But they have to carry more things. They think that it's going to be easier because they can eat anytime, anything they want, which is true, sort of. I think making sure that parents know that they still need to be on top of it. They might not be pulling out the pens and watching their kids give an injection. I think it's easier to forget about your child's diabetes when you think they're just pushing the buttons, and they're not. They're just not, because you rat out kids all the time. And I was thinking the same thing about brushing the teeth. I use that example because I have teenage boys, and I think the parents will be so surprised their kids not giving themselves insulin or not checking their blood sugar. So you'll tell them, you know, they haven't checked their blood sugar in 2 weeks, and they're so surprised. And I'm thinking, I can't get my 14-year-old to brush his teeth really well. Like, why would I expect him to give himself 4 shots a day and check his blood sugar? And I have a really good kid. I feel bad. Please don't tell him. So it's hard. It's not easy. I think a lot of times too, kids when they're 9, 10, 11 are really good about what they're doing. I'm curious if Steve thinks this is true. They're really good at doing the things that they're supposed to do, and the parents are so proud, and the kids come in, they show you their meter, and they like get so much pleasure from having a really great A1C. And so parents get used to allowing them to do a lot of the care, and then they hit 13 or 14 and shit goes sideways. And they just don't know because they've always done it. And there's always kind of this moment where you're ratting their kid out, and the kid's like sweat pouring down and they're shaking, and the parents really like sincerely had no idea. And they'll either fight you back about it, or they'll blame the kid, which frustrates me. And it's sort of like you have to just like, okay, cool. So now we know this has happened. We can argue till the cows come home about who did what, who should have done what, but like, let's figure out a plan now going forward.
I would have to say for adults, probably the compliance or adherence is still, it's not close to 100%. I mean, there's going to be some who are, but I mean, these poor adolescents, they have so many things going on in their brains, and those other hormones are kicking in and everything else. But even adults who we would think would be the prime candidates for this, they still are not close to 100%. It would be tough if you just think about it for yourself, going through a typical day and remembering to do all this stuff. I think it would be very difficult.
It really is, especially type 1 with children and families, a series of losses that get reworked over and over with each developmental phase. So I bet Kathy $1 that I could work Sigmund Freud into our conversation today, and I'm going to do it right now. The 9 to 10-year-olds are in latency, right? They're rule governed, and they're still deeply attached to pleasing authority figures, teachers, school nurses, and parents, typically. And so, yes, but the next loss is when they turn 13, and just as when I asked my kids, did you do your reading for AP history? What's the answer always? Yes, of course. There's a standard blood sugar. Did you test your blood? Yes. What is it? 110. It's always 110. You should be curious. But there's this profound grief and bereavement at diagnosis. And then there's more grieving to be done at the end of the honeymoon period, because during the honeymoon period, I've had people say, you know, this is cake. And what do I do? Do I tell them? The storm hasn't even hit. You know, they're using long-acting insulin once a day, and they think this is managing their type 1 diabetes. And the honeymoon period ends, and all of a sudden, it's disastrous for the kid and for the family. And then they go through another developmental phase and shooting off into, from well-controlled 9 to 10 into adolescence, where everything's going haywire, and biologically as well as psychologically. And so they've got to go through that. And then the family's got to go through maybe sending them off to college. And that now they're truly autonomous, which is just terrifying for many families. So it's a very complex disease to manage, but it's complex to manage medically as well as emotionally. And so the pumps, I mean, when I think of this family, okay, the family that Dr. Eckert mentioned, guilt, no matter what the context or circumstances are, most parents are overrun with guilt. So, and this family may be overrun with guilt about a divorce, but they're also guilty about why their kid got selected with this illness. So dad is really thinking, when he hears pump, what is he thinking? He's actually thinking artificial pancreas. He's not thinking that your kid should have an incredible track record prior to switching over to the pump and managing their diabetes. So there's just a lot of stuff going on emotionally for parents and for their kids, as well as for us. It's a relentless disease, and you can get worn down every bit as much as the family, to a certain extent, though you should never confuse yourself with being in their shoes. Is that reasonable?
Yeah.
I think I'd like to go to my slides just for a second. I want to go back. I kind of mentioned, the increase in incidence, and I want to touch back on maybe why that is. There's some theories behind it, but I think are pretty interesting. And so this is in peds, just a couple of statistics. We still think that type 1 is about 80%, type 2 is 20%. It depends on where you are in the country and which ethnic group you're looking at. In type 2s are higher in Hispanics and African Americans still, and in American Indians as well. And I actually do some diabetes clinics at the Tribal Health Center here in Reno, and we see quite a few kids actually with type 2, as young as 8, 9, 10 years of age. So definitely increasing as BMIs increase as well. But one of the big studies that's been going on now for, probably almost 20 years, I guess. But between 2001 and 2009, there was a 23% increase. That's pretty incredible when you think about it. Now, if you look at other autoimmune disorders, and this is, by the way, I'm talking about type 1 right now. If you look at other autoimmune disorders across the board, thyroid, lupus, MS, anything you can imagine, all of those autoimmune disorders have gone up. And I'll speak to perhaps why that is in just a second. But again, what's interesting is it's most significant in the younger kids. And so some of the autoimmune and environmental theories don't quite make sense with that because they haven't been exposed for as long. But perhaps we're exposing them to a much, much larger degree than in the past. And so we'll talk about the hygiene hypothesis as well. And that's kind of what is linked to this, as well as allergies and other immunological problems. And just briefly, type 2 is also being on the rise about the same amount, 21% increase in that same time period. So that is huge. So the hygiene hypothesis. So with all the hand sanitizers and kids not necessarily playing outside as much and doing more video games and so on, there's not as much exposure to a whole lot of stuff. And some parents are not exposing their kids to eggs or peanuts or what have you, perhaps for a good reason, perhaps because there's a family history of allergies, or they're just worried about it, or all kinds of reasons. But we're maybe seeing fewer infections in the past, and because of this limited exposure. And so with that, the immune systems of these kids are going a little bonkers. And so we're seeing much more of an increase in peanut butter allergies, or peanuts in general, and other allergies. And it's thought to be perhaps one of the causes anyway of the increase in type 1 diabetes. So when the body is exposed, and it hasn't been continuously exposed since birth, it just really jacks up the immune system. And so with that, it attacks things that it's really not supposed to be attacking. Islet cells being one of those. The other hypothesis is the accelerator hypothesis. And I actually think this is probably a bigger problem. And that is that weight gain, even in very, very young kids, is leading to stress of the pancreas. And we can see that very early on. You know, when the BMI starts to rise, if we were to check insulin levels, which, by the way, aren't the greatest of tests, but they kind of give you some idea of how much resistance there is in the periphery to insulin and how taxing it is on the pancreas. When we see those insulin levels going high, we know that there's insulin resistance. And my simplistic view that I talk to mostly adolescents about is you have this much insulin for your entire life, okay? So use it well. And what does that mean? Low simple carbohydrate diet, and be cautious in terms of what you're eating so that you're not constantly stressing your pancreas. So anyway, those are two of the hypotheses. There's probably more to it as well. And again, with everybody being exposed to higher incidence of autoimmune stuff, there's probably more to it. Environmental contamination really is coming to the forefront now. It's just so difficult to tease that out. So the PCBs, the bisphenol A, and things in our plastics, things in our foods that most people are exposed to. This is really frightening to me because these are considered endocrine disruptors. And what does that mean? Well, it means different things to different people. To me, it means that it's really wreaking havoc with that whole pathway of all of the hormones, starting at the hypothalamus, pituitary, and then the individual endocrine glands, and in this case, the pancreas itself. So is it toxic directly to the islet cells? Maybe. I mean, honestly, we don't really know. Nutrition issues, increased exposure to gluten, which is in pretty much anything nowadays, okay? And so that can prompt a pretty significant immune response, and in turn just turns on the immune system in those kids who are predisposed anyway. Early exposure to cow's milk, even formula, has been thought to be part of that. The interesting thing to me, though, is that Finland has the highest rate of type 1 diabetes in the world. They also have the highest rate of breastfeeding for the longest period of time. Doesn't really make sense. Now, I'm not sure what their stats are for younger kids, and maybe they see it later. I'm really not sure about that. But that has always fascinated me because we've known about that for 25 years, the breastfeeding incidence and so on, and still they have a very high incidence. Now, it's a small country, and with that, I'm sure there's a lot of interfamilial, for lack of a better term, breeding, pregnancies within families and so on. So that may be part of it. Okay. And then vitamin D deficiency, it's been proposed more in terms of type 2 diabetes, but one would wonder about type 1 as well. Vitamin D seems to be playing a much bigger role in a whole lot of different diseases, including heart disease, other autoimmune disorders, strokes, cancers, and so on. So I find this really interesting, and the search study that I briefly mentioned before is kind of looking into some of these things, but this takes decades really to try to tease out. Okay, so we're going to have another topic next month about type 2 diabetes, and I'll go into that more. But I was just at a meeting not too long ago, and we were really talking about the in utero environment and what that does to a baby going forward, and it's fascinating. Women who are obese before pregnancy carry with them this environment and a setup for their babies. And even if they're not obese before, but they gain a significant amount of weight during pregnancy, they also set up a different milieu for these babies that leads to a higher incidence of obesity, higher incidence of insulin resistance, and ultimately type 2 diabetes. And there's a lot of interesting research that's just starting to happen. It's fascinating. And even if those kids are not necessarily overweight at the time, they still have an increased incidence of type 2 diabetes. So I think there's going to be a lot more interesting research coming out on that in the near future. So I'm not going to talk more about type 2. What I'd like to do is just open it to you guys if you have any questions that you'd like to ask. Or other comments, Yolanda, you want to make?
No.
Do we have any questions for Dr. Eckert or Yolanda?
So if there's no questions, any suggestions you have on how we can make this more appropriate for you guys? What do you want to learn about? What can we talk to you about? Is it better to bring case studies from both sides, really? And we'll be happy to do that. I mean, I think that's one of the great things we can do maybe next time or the following is we'll bring in some logbooks, some downloads from meters, and really kind of go over those, like how to adjust insulin and what are those different types of insulins that we typically use and so on. Okay. How about from your angle? I mean, we welcome any input. We just want to make this as educational as possible for everybody. Not to put you on the spot. Okay, you can always email us too. Is there a common email that they can just send to?
Yeah, I'll send it out in the chat, but it's just projectecho@med.unr.edu.
And even if you can just sort of tell us if there was anything that we touched on today that was particularly helpful, I think that would be good for me to know sort of where to spend my time and what to focus on.
Okay, if there's no questions, I guess we'll sign off. Did you have any questions? No? Okay, great. Okay.
I have one question.
Please go ahead.
Yeah, so my name is Umar. I'm looking for medical residency here at UNR. I'm not in clinical practice, but my question is, do you guys use any kind of inhaled insulin in clinical practice regarding pediatric populations?
Say that again?
Do you use any inhaled insulin in clinical practice?
We do not. It's not FDA approved for young people quite yet. I think the lower age limit is 18. And that's a great question. And I really don't have any experience with it because of the FDA indication. And honestly, I shied away from it several years ago when it was first out and then it was taken off the market. My biggest concern is insulin is a growth factor, and you're inhaling it into young lungs that are still developing. And I do have some concerns about that. So, we ended up having some problems with the first inhaled. I'm not really clear on exactly what the details are on the differences between the first one and the current one. And maybe you can enlighten me. But currently, the answer to your question is we don't use it.
Okay. Just
you have experience with it?
Use that.
You've not used it?
No, I haven't used it, but I was just curious that if you use that or not.
Yeah. And we have quite a large armamentarium now of different insulins, with newer ones coming out and so on. Toujeo has been really nice. Just in case you happen to forget it, you're kind of covered for a little longer, and that's been really nice.
And one more question, sorry. Do we have any data about increased incidence of diabetes mellitus in children who are born to consanguineous marriages?
I don't know that there is specific data. My guess would be that it's higher in those families who are affected with type 1 diabetes, just like other autoimmune disorders. But the data even on identical twins, it's not 100%. So clearly there's a whole lot more than genetics going on. It's about 50% in identical twins. And fraternal twins, it's the same as the general population. About 3% of the time a fraternal twin or another sibling would also get diabetes. So not super high. Interesting.
Okay, thank you.
So there's another question. What kind of treatment or recommendations do you have for teens and young adults struggling with diabetes and eating disorders? I am so happy you asked that question.
Yeah.
That is a fascinating disorder to me. And unfortunately, there aren't a lot of great resources. And starting with diagnosing, it's very, very difficult to diagnose. Many years ago, Steve Graybar, who's here, we started an eating disorder combined with type 1 diabetes program at our local residential treatment center that mainly takes care of young adults who have just eating disorders without diabetes. And the pathology and psychology is fascinating. So number one, making that diagnosis. And the statistics would suggest that up to 40% of females, at least, have concordant, coinciding eating disorder with type 1 diabetes. So it's really, really high. And anybody's A1C who's over 9% or so, at least in the adult population, should be considered to have an eating disorder. Now, we've seen exceptions to that, where they're doing all kinds of things. So it has to be on your radar all the time. And so if you're seeing funky numbers and especially an older teen, and especially a girl, not to say it can't happen in boys, because it definitely does, but we just don't have very much data on that. If you're seeing things where the A1C is high and out of keeping with what you think should be happening, or lots of highs and lots of lows, they may be binging, purging, overdoing insulin in order to take care of that binge. I mean, there is so many facets of eating disorders with diabetes, it's incredible. So they may be doing exactly the same as someone without diabetes, but on top of it, missing out on 20% of their insulin. And people are so good about figuring out how much insulin they need to stay out of DKA. So they can just barely scoot along, stay out of the hospital, but urinate out so many calories. You can easily lose 5-10 pounds in a weekend if you're really good at this. And they do. I mean, prom weekend, the week leading up to that, you skip 20% of your insulin every day or 50% of your insulin, you're going to fit nicely into your prom dress. And people do that all the time. Frightening, because the complication rate is so much higher and so much sooner than the general population with type 1 diabetes who are managing their diabetes well. As far as treatment, we do have the residential treatment program. They go down as young as 16, I believe. Outpatient, there's not something really set in stone, but Yolanda helps manage those patients. We have a new adolescent medicine specialist in Reno who has an eating disorder clinic now, and we're going to try and incorporate diabetes as part of that as well, because it is a different beast. A lot of the same issues, of course. Okay.
I think too that early on when they're first diagnosed, the things that I talked about, like trying to not have it totally rock their world. They can still eat the things that they like to eat before. I try to head it off at the pass. Sometimes parents, especially with little kids, will do this thing where they say, well, if you eat this, something that doesn't have any carb, then you won't have to take a shot. And it sets up this whole just mind frame. So I try to really head those little things off at the pass and minimize, the I was good or bad or the anxiety around a specific blood sugar, because sometimes you can see it coming. Yeah.
And
are there any online resources or programs that you would refer parents to when they have a young child diagnosed with diabetes to kind of learn that new way of communication and talking about diet?
Well, I offer as much as possible so parents can come in without their kids to meet with me. They don't do as much of that. I think usually what parents do is they seek support from other families who have type 1, which can be good or bad depending on how that goes. I give a lot of numbers for therapists because I do think that that's a huge part of it is the whole family. I feel everybody can benefit from just therapy in general, regardless. But certainly if you have a chronic illness, that's helpful. And then for us to work as a team and be in contact with the therapist so we know what what each other is doing is probably the best.
there's also our local, statewide Nevada Diabetes Association, and they do have usually monthly get-togethers for the kids and sometimes for the parents as well. And then they have other resources that they can refer to. A lot of patients, especially who are not in Reno or Vegas, do go online to blogs and so on, and you have to be pretty careful about that, because not every typical person is on those blogs, and so you have the outliers, so to speak, on either end. And so sometimes we hear some kind of crazy things being said on those blogs. So just like with any disorder or anything you're blogging about, have to be a little bit cautious with that. So, but I think the Nevada Diabetes Association is a really good support system. JDRF, there are support groups. They're mostly research. They do have an annual or semi-annual research meeting that they have here. A guest speaker comes. A lot of parents really like that. But most parents are just kind of bogged down in the day-to-day stuff, and that's what they need help with. They're not looking 20 years from now for what the next pancreatic transplant is going to do for them. So it's the day-to-day. I want to make one other comment as far as the weight issues and eating disorders. It's so easy, especially for teenagers when they're first diagnosed. They recognize that they came in the hospital 20 pounds lighter, and we started insulin on them, and within 2 weeks, they regained that 20 pounds. It doesn't take a rocket scientist to put all that together, right? And so I think very quickly they learn to maybe ration their food, but more importantly, they really, really ration their insulin because they know they can keep their weight down that way. And so helping them to slowly regain that weight and helping them understand why it's important that they regain at least most of that weight, although many of ours are overweight to begin with, I think is really important in keeping that healthy mental aspect to what's going on with their diabetes and weight and eating disorders. All right, any other questions or comments? Thank you for joining us. And we look forward to seeing you hopefully next month. And we'll chat primarily about type 2 diabetes and other types of non-type 1, type 2, such as maturity onset diabetes, infantile or neonatal diabetes, and so on. Okay? All right, thank you. See ya.